Good afternoon, everyone. Thank you for feliciting this occasion with your physical presence. I think physical presence I'm stressing because post-COVID now it is time to reconnect and good to see everybody in person. It definitely has a different impact when we catch up each other virtually than personally. So before we go and deep dive into track one, I would just like to set a brief context, like what this health dialogue series we are talking about and what PPHF has done when we are talking about the COVID pandemic response. So COVID-19 is a phenomenon everybody among us has witnessed some or other aspect, whether it's personal agony, whether it is financial crisis, or we ourselves have suffered. So as here we can summarize, it is the social isolation, increased morbidity, mortality, financial difficulties, etc. So what and how PPHF has responded in last 2 years when it comes to COVID. Just to give us a brief background, PPHF has an extensive disaster management experience, and that experience helped us to dive in action mode very early when the COVID pandemic started. So we are among the earliest organization who could mobilize the resources and help the people and institute in need. So what did we do? We set up a PPHF COVID-19 response fund. The 5 strategies or the 5 modes of operations are, first of all, we focused on strengthening the health system. And when I say strengthening the health system, it is basically medical equipment supplies, but along with that, we also helped set up the community and provided safety kits to the society. So as Dr. Palo was mentioning, just the 132 hospitals scattered in 20 states pan-India through a huge support of our donors, where we could facilitate and ensure. So total impact we created via our COVID initiatives, we could reach out 44.5 million people, and I think that's a commendable number when we see the outreach and impact of this initiative. So what we did, we had a two-sided strategy. One was definitely that working on an acute need, getting exactly what the hospital is needing. So it is form of mobilizing the resources. But second and most important is continuing the healthcare services in the community via government. And here, who played the crucial role? The community volunteers played a very crucial role to bridge this gap, because if you remember that time, there were so many restrictions when it comes to travel, healthcare, and people were isolated inside their homes. They were panicking and they were losing faith. So this community volunteers helped to ensure that the anxiety is getting reduced and they are getting back their confidence to reach to the healthcare centers. We did a rapid assessment in the community, in the field, in the hospital to know exact need, and we mobilized the support from the donors for it. We also provided virtual training, not only to the doctors, but also to the volunteers who came forward so that they can go back to the community and help to relieve the anxiety, because mental health was the biggest issue we could sense, and still we are feeling that it is causing a major burnout for the people who have suffered directly or indirectly from the COVID. And we also helped to catalyze using digital services, telemedicine services, so that the more number of patients can access the healthcare without getting into the physical touch or without coming into the physical vicinity to the healthcare centers. We provided COVID-19 vaccination. So the uniqueness of our drive that we focused on the vulnerable population, whether it is migrant worker, truck drivers, sanitation workers, and also to the tribal hard to reach area, whether it is Nandurbar in Maharashtra or some tribal core district in Odisha. Then we also ensured that all the activities which are, so PPHF also has some core health activities. So we ensured that people who are now been kind of a cutoff, there was call to action and lot of community mobilization drive we did, so that there would be increased uptake of health services from the community to the health center, apart from training the people who are at the health center. And I think most crucial part when we say is micromanaging the supply chain system. When I say micromanaging, yes, there is a logistics system, there is a chain, how things comes to the district, how things percolate. But when you see in the field, in the practicality, there is a huge gap. So we try to work on that gap and ensure that the people who require, the institute who require, get the desired support in that need of hour. We also facilitated delivery of primary health services and social safety net program, I think, which is very crucial because people were left vulnerable financially. So we ensured through our community health volunteers and through our various, so we are extended pan-India, so we ensured that the local team what we have are ensuring that the support is getting mobilized and somewhere the gap is getting closed in the communication as well in the logistics supply. What did we learn? As I said, mental health challenge was the biggest challenge we can list when we said about the learning. It has kind of, so mental health burden issue is definitely a silent pandemic, but I think COVID put a spotlight onto it and it has added into it. And one of my colleagues, I know she is working very corely in mental health, so I think she would also corroborate with what I'm saying. And so another aspect we see is we really have to work very close and very minutely when it comes to the supply chain. Supply chain at a micro level, not at a bigger level, but at a micro level. So this is an area we potentially see lot of work need to be done, and this will help to make the health system resilience, building the resilience of the health system so that they can cope up with the, should not happen, but if it happen, then we should learn from the learning what we had. And we are also working so that how we can do a community level health services through the various digital initiatives. This is what we are working on, and we really want to explore this space as much as possible because it looks like a more sustainable option and a long-term option when it comes to the service delivery section. And we ensure that, you know, that every level, no matter what, every level, whether it is your health and wellness center, whether it is your CSC, whether it's your PSC, whether it's your all the tertiary, every level need to be ready so that next time we are struck with a tragedy, we are resilient, we'll bounce back more quickly and will ensure that these kind of gaps should not happen. So why Health Dialogue series? So Health Dialogue series, basically it's a platform. So as I just told you that PPHF has recognized, and we have recognized that it's a growing need that all the healthcare sector partners who have experienced a similar work, who have done the similar work, maybe on a different domain, should come together and talk about it, because our collective learning will only help us to answer the current and the future need. And all this learning together only will ensure that we have a resilient system built up to face the new upcoming challenges. So non-communicable disease, I am quite aware about the audiences, so I don't have to say the statement that NCD is the leading cause of death and India is a global capital for diabetes and all. We all are aware about that. So what we are trying to tell you via this platform, what we have learned through our programs, which we did at community level for NCDs. So this is the summary, this is the insight from the field. When we talk about the service delivery aspect, there was a complete disruption of NCD services. So when I say NCD services, I think COVID shifted the gear and changed the priority, which was definitely a need of the hour, that yes, COVID had to be prioritized, whether it is clinical services or whether it is vaccination. But because of that, the momentum which NPCDC's program has picked up got derailed and there was a disruption. And we all are aware that India has adopted population-based screening strategy in their NPCDCS program that practically came to standstill because all possible health resources were mobilized for the COVID care. This was the challenge. Again, people were scared. Nobody wanted to step outside unless it is really emergency. So the point of care of diagnosis of NPCDCS program, where we were screening passive population coming to the health center, also significantly decreased. And it is not only the outpatient flow, but also the inpatient flow also decreased because there were availability of bed was reduced. And the beds were again prioritized for COVID care. Lastly is again inadequate availability of the medicine and diagnostics. So these were the service delivery challenges which we observed through our community programs. Now when I say community programs, what were the challenges which were faced by the community? There was lot of fear, lot of mistrust. And mistrust, when I say, it is not only hospital people, only the doctor who is wearing the apron. Anybody coming saying that I am from health services, I am a community volunteer, I am a community mobilizer, people would say, "Dur rahiye, step aside, we don't want to get in touch with you, we don't want to give you any info." So that kind of mistrust and fear was there, it was very difficult to overcome. Second, because we had this lockdown and lot of restrictions, so the NCD risk factors, because people were spending much time in indoor, and which ultimately resulted in highly unhealthy diet, alcohol consumption, and stress has mounted their level up. Again, people who were diagnosed with NCDs had difficulty to obtain their medicines. There were I would not say lack of, but inadequate access. Access is the better word, because of certain restrictions were placed at that time. Plus, there were travel and transport restrictions, so it was difficult for people to go to their doctors and seek the care required. And plus, financial difficulties really, and as we know that out-of-pocket expenditure is one of a known phenomenon when we talk about the public health program. So out-of-pocket expenditure in presence of financial difficulties had really made the situation worse. So this is a disease loop. This is how we like to describe the NCD situation, or we called it a kind of a vicious circle where you could see that COVID-19 caused restrictions. It brought lot of restriction, whether it is access to healthcare, whether it is increasing the risk factor to the NCDs, and that has also resulted in lack of quality care which was dedicated to NCD. This has further resulted in uncontrolled NCDs, and all the data, all the report, all the morbidity, mortality data has clearly indicated that the people who are having a non-communicable disease are highly prone, and they have a very poor prognosis when it comes to the COVID. So this was a kind of a vicious circle. So we really need to work to ensure that we break this loop, so that the people can be early screened, diagnosed, adherent to the treatment, as well as we work at a community level so the risk factor level can reduce. So what we are doing in NCDs and in our community initiative, this is a 4-pillar approach where we work. We work with the PSCs or the health center. We work by doing the capacity building of the healthcare workers, and we work parallelly with the community to increase their awareness that there are these services available in your nearest health center. Please go and seek it. We also work so that they are aware about the different risk factors, that how they should refrain from it. And not along with that, as I said, that population-based screening is one of the most important pillar where NPCDCS is also working. So we ensure that we are working with the system to strengthen and achieve the population coverage via this initiative. Last, but I think it is one of the most crucial parts, we also try to link the people with the insurance scheme of whatever state we are working, so that the people are into the safety net and they don't have to bear the expenses. So this is how we are working in the field, that we are in the field, we do the population enumeration, create and make sure that the population is into the CPSC database, and then we get the eligible number, we work with the health system. So we facilitate strengthen the system so that whatever efforts we are doing in the field are sustainable. So whatever we are doing along with the infrastructure and existing human resources. So challenges I talk about when I talk about what challenges we faced in community level and service level. So these are the solutions what we could come up and we implied, and that gave us a result. So as I said that COVID-19 changed the gear and lot of resources, human resources were mobilized toward the COVID care and vaccination. So we mobilized the ground support at the community level so that the population-based screening can happen at the population convenience, whether it is at their home, whether it is the nearest sub-center. We ensure that it happens, and we use the local people from the community. We are actually trying out studying a community mobilizer approach in urban aspect. It is regarding NCD. So that community mobilizers also came very handy when we talk about the community mobilization. And I think any public health expert sitting in India, worked in India, will have a concurrence with me that we really need a good data. So we ensured that whoever we are approaching gets enter into the government portal, and the database, the efforts we are putting are getting into the database so that the, I would say, administrator can inform choices. Okay, this many people are there. Okay, this many people have been screened. Okay, this is what the prevalence looks like in my PSC. Secondly, we also did training, and training we did not limit it to the NCD, but it was again a need-based training. People said we need ECG training. We ensured that they get the ECG training. We ensured, because there was difficulty to gather people and give the physical training, and the cancer screening took a really backseat. When I talk about NCD screening, cancer screening really took a backseat. So we helped with a hybrid model, where technical experts from Tata Cancer Hospital and ACS could do a virtual theoretical training, and hands-on training was given at the sub-center level in a small group. So that worked very well with us. So this is, you can say, a few solutions we could come up while looking at the challenges which COVID had put in front of us. And last but not the least, we heavily rely on community engagement in all our health initiative. So when I say community engagement, it is not only about going to the community and enumerating and taking their data. No. It is also making the community aware about their rights, about the services what is available, and about how we can educate them, especially when it comes to the risk factors. So these are the few practical things we did which helped us to ensure that things are coming little back on track when it comes to the NCD. I will just take two minutes from my colleagues who are working and taking care of NCD initiatives in Telangana and Assam to add any solutions or practical things you want to add what I have just said. Monica, would you like to go first? So Monica is our state program manager at Hyderabad, Medchal district.
They are entering into the community, these people are like not allowed, because people are scared that they might get COVID, and they are like, no, like don't come inside, we are not allowed, and we will not give our information. And also what we did is, like, we took a help of the ward members, because we mostly work in the urban areas of urban slums. So ward members helped us to take them to the near to the community, to sensitize them and to come to the centers for getting screened. So this was one we have seen.
Thank
Pass
you.
it to Bhaswati.
Yeah. So Dr. Bhaswati Pathak, she is our state program manager for Assam. She is based in Guwahati and looking at Kamrup and Barpeta area.
Sure.
Yeah, why not?
Good afternoon. Ma'am has already given my introduction. So I am working on NCDs under a project called SCREEN. In this project, we tried to orient all the government workers, starting from the medical officers to the ASHAs. All of them form one team, and they needed to know it. They needed to work in coordination. So in our first component, training, we made sure that they knew they are working towards the same goal. There was this common excuse saying that COVID vaccination is there, we have to give the booster dosages, and there was this har ghar dastak which became a big barrier in implementation, for implementation of NCD activities. So what we did, we gathered all the ASHAs. They anyways had to go for vaccination, har ghar dastak, even the Anganwadis, and everybody had to do that. What we made sure is whenever they went to the people's house, door-to-door house, they also gave them awareness about NCDs. So this was an opportunity which they could grasp and also create awareness of a very important factor which was causing mortality in the community. The project was basically based in Swalkuchi in the Kamrup district and Borpeta district in a block called the Borpeta Road block. So the training was basically focused on making proper groups and to utilize the government resources only so that the effect is long lasting. And even when we are not there, they are able to do it individually. So upskilling them and increasing the capacity to make them independent and know how important NCDs are. Secondly, to overcome the community restrictions, we made sure to arrange outreach camps. Outreach camps is already a plan in the government module, in their activities. So during COVID, there were no outreach camps. Most of the sub-centers were closed because the health workers were diverted for COVID activities. We organized camps at sub-center levels in each village that the sub-center covered. And the ASHAs were responsible for mobilizing the people and also educating them. That way, we reached out to the community, increased awareness and also the importance of NCDs. This way, we were able to make sure to make them understand how important it is along with COVID. Because they were already getting vaccinated, but even the CHOs, they had this excuse that we need to give vaccinations, but they were not aware and they didn't realize that as for communicable diseases, we need vaccination for prevention. But for non-communicable diseases, it's early diagnosis and prompt treatment, which can be done only when we are able to screen for the NCDs. When we screened, we found there were people who had blood sugar levels, random blood sugar levels of 400, and they were not aware that they were suffering from a disease, which obviously ultimately would have been diagnosed with diabetes. And also hypertension was diagnosed in many of the people there. So when the peers, the community members also saw that the community people are getting diagnosed with high blood sugar levels and also high blood pressure levels, they learned from themselves and they made sure to visit the camps. They knew that 2 days in every week was designated for NCDs, so we made them aware that it has already been arranged. I think so I have taken too long. And these are the two main things, how we worked on tried to improve the NCD services.
Thank you so much, Baswati, for your insight. So after this, I would like to invite our esteemed panelists. I would like to invite first Dr. Sudarshan Mandal, sir. He is a Deputy Director General of NCD. Sir did his MBBS from NRS Medical College, Kolkata, and MD in Public Health, All India Institute of Hygiene and Public Health, Kolkata. And sir has joined Directorate General of Health Services as Deputy Director General, NPCDSS, and started work from 16th December 2021. And I must say, from the all personal interaction, he is one of the most enthusiastic DDG I have seen. So thank you so much, sir. And he's a public health specialist with a very vast teaching experience. Please join the dais, sir. Please come. After this, I would like to invite Dr. K. Madan Gopal sir. He is a senior consultant with Niti Aayog. He is a public health professional with MBBS MD qualification, and he has extensive experience when it comes to the health system reforms and strengthening in India for around 30 years. So thank you so much, sir, for agreeing and joining this session. Now I would like to invite Dr. Bhavna Sharma ma'am. She is a country lead to Resolve to Save Life, and she has 24 years of experience developing and overseeing implementing drug delivery and clinical research. And she is looking after IHCA initiative in India. Thank you so much for joining us, ma'am. I would like to invite Dr. Akash Malik sir. Dr. Akash Malik is a medical doctor and public health expert with more than 10 years of experience, and he has worked with prestigious organizations like Ministry of Health and Family Welfare. Currently, he is working with UNDP. Thank you so much for joining. I would like to invite Dr. Palu sir. Dr. Lakshmikant Palu is a CEO of PPHF, and I would like him to moderate this session, sir. Thank you so much.
No, thank you. Thank you for having little diverse panel today. And primarily, we discuss what as an organization we learn in this COVID period. Couple of our lessons from beginning of 2020, because we have several state NCD program at that time. I think 7-8 states across India, and most of the aspirational districts also part of the program. So a lot of those lessons also. And when the COVID wave 1 and 2 happened, a lot of these programs also stopped. Then we started, how to really working at the community level. A lot of those strategies that we tried, and many of them are success, many of them not. But to start with, when the idea of this series that we came to us, when we were trying to put some learnings from COVID and how the regular health services were disturbed, then we are trying to search all WHO publications, Ministry of Health, other guidelines and COVID guidelines. But I really personally find also where there is a single window or platform where we can get all collective learnings for India at least together. I could not find. Probably you have the same issues. So that's one triggering point for us to, can we see something, where we go to get the learnings. If we want to continue and address these things in future, where is that platform or window, or maybe most of the information can be gathered. Whether Ministry of Health platform, or it's a Niti Aayog, or it's a WHO or any development partners, or there is a common platform where we get. Really, we had little difficulties today also, if you see go, and people, agencies and organizations have their own experience. They are hosting this kind of maybe small gatherings, but we really find, maybe that's one message to Ministry of Health. Can we see some way of putting things together and asking? So maybe I will start with Dr. Mandal to give a little perspective about this. And primarily, sir, when you talked about this, about what is the learning during COVID, because we all responded COVID, that was a first priority. But while responding to COVID, what we did to continue our NCD programs, and what are those lessons we can take it forward. Thank you, sir.
Thank you very much. Yeah, thank you, Dr. Lakshmikant Palu, for hosting this type of event at this beautiful venue. I must congratulate you, and I convey my best wishes for the program. It has been successful, I think, since morning, and I wish to be successful till end of the program. Thank you very much. You have put so many questions before me. So first, I think you have put one question, that where you will get all the informations, the guidelines, the directives, and various type of informations, the orders, from which place? I mean, is there is a single website or single place where you can get all the information? I mean, this is your first questions, I think. So from the ministry side, I am a ministry person. So from the ministry side, I can say there is a website, a robust website of the Ministry of Health and Family Welfare. And apart from that, you know, there is a website for our Directorate General Health Services. And for different programs also, they have their own website. I can give you an example of, you know, that NTEP. National Tuberculosis Elimination Program, they have a robust website where all the guidelines, all the directives, all the letters, even DO letters and other official letters are put there. I mean, you can search for it and you can get everything. Since I think 2003, I mean, all those reports, that annual TB report and everything, even the global TB report, you will get there. Those were uploaded from time to time. So you will get all those information as far as that NTP concerned. As far as other programs which are working under the Directorate, Director General Health Service, you will get it from the Directorate website, DGHS website. And also we have a separate website for International Health Division. For NCD divisions, we are thinking of, I mean, creating or developing one website there. And you know, I am glad to announce here that our name of the program has been changed from that NCD cell to National NCD divisions now. I mean, it will give more emphasis to the program, and as because we have to, I mean, we have to make aware this program nationally and internationally, we did it actually. And that communication has been sent to all the stakeholders, including our development partners and all the states and union territories. So that kind of information you will get from the websites. There are many websites, other websites also. So there is little time to mention all the websites, but mainly you can get it from the ministry website, from the directorate website, and for the specific program, vertical program, you will get it from the website of that concerned, I mean, you will website of that concerned vertical program like TB and International Health Division. There is a POE website for International Health Division. So I think regarding the first questions, can I satisfy you?
Yes, sir. Yes, sir.
And what was your second question?
Yes, second question, what is your experience in last 2 years during COVID, and how you have managed the ongoing NCD program while responding to COVID?
So regarding 2 years experience, you know, most of the period of COVID, I worked in central TB divisions for that NTEP, National Tuberculosis Elimination Program. But for last 6 months, I've been working here for both International Health Division and non-communicable disease program. So I can say that, I mean, my experience or the program experience, it's my experience or the program experience?
Program experience.
Program experience.
Implementing, you know, how you manage, because you were fighting at two fronts. One is the COVID response, at the same time also the ongoing NCD program.
So before that, you allotted 1 hour time to us for panel discussion, and I mean that presentation done by Dr. Sona is very nice presentation, sir. I appreciate for that. But it's now 2:40. We have started just 5 minutes before. So can I get sufficient time to speak about all those things, all those answers to your question? Yeah. So I should come here, or I can do it here? So before that, I think before answering to other queries you have raised, let me, because I got this scope here to spotlight the activities of our National NCD Division program. And what is that? I mean, many people don't know the name of NPCDCS and also National NCD Division, even state STD cells and NCD cell of the districts and CSCs and health and wellness center. Let me just, can I take just 3-4 minutes to narrate about the burden of disease in the country? And I think I got a good audience here. At least for the audience, I can say that you know that in the world, I think most of you know that every year 55 million die. Every year that 55 million, and out of which 41 million people, which equals to 71% of the total deaths of globally from NCD, and that death is attributable to NCD only. So that's a huge, burden for NCD in the world. And as far as India is concerned, it's about 63% of the total death. I mean, in India, you know that every year we are losing most probably 10 million people, 1 crore people every year we are losing. And out of 1 crore or 10 million, 63% of the deaths are attributable to NCDs only. 63 lakhs or 62 lakhs from NCD. That can speak about the burden of the disease in the country. And regarding, Dr. Sona has mentioned about out-of-pocket expenditure. That is also huge for our country. If you consider the total out-of expenditure for our common citizens, for NCD only 47% of the total out-of expenditure only by this NCD diseases, like you know that hypertension, diabetes, and cardiovascular disease, stroke, and there are other 3 diseases also, COPD, and non-alcoholic fatty liver disease, and chronic kidney disease. So 47% out of expenditure only due to, that has been probably increased during the COVID period, maybe more than 47%, but record says that now it's 47% of the total out of expenditure. So that is about the burden of disease. And you know that I want to give 2 examples. If you permit me more time, I am giving you 2 examples. At a point of time, you know that we have, even we consider today's figure, we have probably 35 lakhs cancer cases in the country. It consists of so many diseases. I am taking example of cancer, and out of 35 lakhs cancer in the country, probably 50% of those, those cancer diagnosed are getting, affordable treatment, and rest 50% probably are not getting. So that is one figure. And if you consider the chronic kidney disease, and particularly the end-stage renal disease, which requires either hemodialysis or kidney transplantation or peritoneal dialysis. Peritoneal dialysis, only we can do for a small percentage of patients since 2020. At a point of time, we have 4 lakhs cases of that type of end-stage renal disease who requires that type of 3 modality of treatment. And probably 2 lakh cases are being treated by our, government or private health facility. Another 2 lakh cases probably now they are not getting. That's why probably 2 lakh cases die every year from end-stage renal disease also. So this speaks about the burden related. I am giving example of only chronic kidney disease and cancer. There are so many examples. So now a question arises that what we are doing. Are we sitting idle, or we are doing something for our NCD patients? So if we start from the bottom, and the most peripheral level health facility is sub-center. Most of the sub-center, of course, are converted to health and wellness center. And we have now, that 118,000 health and wellness center in the country. 1.18 lakh health and wellness center out of proposed 1.5 lakh. By the end of this year, probably we'll get that figure of 1.5 lakh health and wellness center. So what we are doing at that health and wellness center, that CHO and other 7 staffs are there. Altogether, there are 8 personnels for doing the job of health and wellness center. What they are doing, they have to do 12 activities. And out of 12 activities, there is MCH, neonatal health, child health, adolescent health, and so many. Even communicable disease, leprosy, and tuberculosis is included there in their activity. So apart from that, also NCD is there. The prevention and control of NCD, and also screening of NCD at the health and wellness center. Luckily, we have started that project of Ayushman Bharat in 2018. That's why we are doing at the most peripheral. The idea is that whether we can bring some health facility at the, at the close to the level of that doorstep of our patient. And you know that one health and wellness center caters to a population of 5 to 8,000 population only, and there are 8 staff, including a CHO. So we are doing that. So NCD activity at the health and wellness center, and PSC, you know, they are doing the screening and other activities. That is a place of that initial prescription by MO and also continuation of treatment there. And then CSC level, I can say most of the CSC, they have started that NCD clinic. And now figure tells about that we have now 5,408 NCD clinic at the CSC level, community health center level. And for the district level, you know that in the country we have probably now 748 administrative districts. Out of 748 administrative districts, we have started our NCD unit in 694 districts, and also we have started that NCD clinic activity in 584 districts. And apart from that, at the tertiary care level, I can say that we have started to develop State Cancer Institute, tertiary cancer care center, and also that district level cardiac care unit, district level day care unit, so many things. So we are doing, we are doing the job for our common citizens at various levels, starting from that the sub-center or health and wellness center to the apex hospitals of the state. So things are doing, we are doing that things. We are trying to strengthen further our national NCD divisions, state NCD cell, district NCD cell, CSC NCD cells, so that they can cope up with the huge workload of NCD by strengthening their infrastructure, by strengthening their human resources, by strengthening their equipment. You know that at the peripheral level, you need only one glucometer and strips for diagnosing a diabetes patient, and for diagnosing a hypertension, you need only one, a BP instrument. Maybe it may be a digital BP instrument. So that type of things we have put in various places to diagnose, to start treatment early, and to ensure that there is continuum care. Thank you very much. This is about the burden of disease and intervention we are doing through our program.
Okay. Thank you, sir. One very specific question. Is there a lot of learnings coming at the ministry level from different states and the more kind of policy perspective and program implementation experience? Is there a system you have captured all those NCD related program implementation experience during COVID period and post also? Is there any document, anything that is something is a good idea to do that?
So you are talking about best practices, whether we are documenting the best practices done by the states and various district level managers and other also during the COVID period.
And the learnings for future.
Yeah. So I will just mention the names of the best practices apart from what best practices we did for our at the central level, at the national level. You know that, already most of the best practices have been narrated by Dr. Sona. So, you have given little scope for me. I was, viewing your presentation. So, almost similar, but let me speak about from government side. As far as best practice is concerned, and first I have to admit that COVID-19 posed a very, different types of challenges to the health system of India. And you know that most of the health facilities, particularly the apex level health facilities, the district level health facilities particularly, they were repurposed for COVID-19 management. Number one. Number two, our human resources also, they are also repurposed for COVID management. And during the lockdown period of 85 days, I think 84 or 85 days, in 4 phases, that was started on 24th March, and that has been continued to, I think, 31st May. The total, I mean, talking about total lockdown. So what you did actually? Number one best practice we did, we had taken the data from the state that what is your reserve of drugs. I mean, your drug reserve at different level. Though most of the state, they have mentioned that they had at that time, I mean, that is the time of April 2020, they had 4 to 6 months reserve at the state level, most of the state, big states and medium-sized state, and also some of the small state and UTs. So we considered that even if I mean, lockdown period continued up to 3 months or 4 months, we can manage that in most of the state. And we had taken also data that whether there is any shortage of medicines. So most of the state have mentioned that there were no shortage of medicine actually. And in some pockets of the states and union territories, what we did actually, we have allowed them to issue medicines for a period of 3 months instead of 15 days. I mean, usually we give medicines for, that antihypertensive or anti-diabetic drug for a period of 2 weeks. So we issued one, notification or guidelines to the state on 14th April 2020 that now the center has considered to issue medicine for a period of 3 months instead of having that 2 weeks. So that we issued that type of guidelines, and most of that followed that. I mean, Karnataka has followed for hypertension, Maharashtra also they have followed for 3 months, UP also. I mean, state is a health chapter. I mean, they can customize the guidelines, they can, modify the guidelines according to their view. This is the first, good practice. And second one, I can mention that, we have started doorstep delivery of medicines. And most of the southern state, the Andhra, Telangana, Tamil Nadu, they started the doorstep delivery of medicines because, that during the COVID period, our, patients, NCD patients, they could not come to the health facility for various type of reason. I mean, that there was disruption of traffic or transport, number one. Number two, maybe few health facilities were closed at that time. And number three, the fear factor. The fear factor, fear of getting infections. If you come in contact with the healthcare provider or you come to the health facility, you may get infected. So what we did, we sent another advisory that can you consider doorstep delivery of medicines so that our beneficiary don't have to come to the health facility. Our people, our most peripheral worker, ASAs and ANM or even CHOs, they can go to the doorstep of the facility with medicines of a period of 2 to 3 months and delivered to you at your doorstep. That is one of the best practices. Second one. Third one, that in May 2020, we have started e-Sanjamani, the teleconsultation. If you provide medicine also, there may be side effect medicines. Particularly if you consider the anti-TB drugs and other drugs, there is huge side effect. For DRTB patient, for drug sensitive patient. So what we did, we have started e-Sanjamani from our central level, and it was spread to all the states and most peripheral level also. And now teleconsultation has been started from the health and wellness center, so that the patient or the beneficiary can have contact with the healthcare provider, the MO of the PSC or specialist of the district hospital or medical officer of the district hospital. That we have started. That is one of the best practices. Again, if you consider other best practices, we have started virtual meeting. In TB division, we did so many virtual meeting. I think that was happening also in NCD division also. So to keep, the energy level of our healthcare provider at the optimum level, we started the meeting, virtual conference meeting with the state health manager, with the district health manager. From time to time, even I can give you example of international health. We held everyday meeting, every day in the evening 5 to 6:30. We held meeting with our subordinate offices on a regular basis. So these are the very, those have been mentioned by Dr. Sonas. Dr. Sona,
Thank
you
you,
did
sir.
so many job for me actually.
Thank you, sir. Thank you, sir. Dr. Madan, from a planning Niti Aayog's perspective, what some of the lessons learned from a policy perspective also, and some of the directives for program implementation, and what is the way forward that you see? Those are the experience that we had in last 2 years, and more kind of program implementation experience going forward, sir.
Thank you, Dr. Lakshmikant. One of the important things which we all miss is what we did in the last 2 years. From the fear psychosis to the confidence, which the way we have transitioned, we have to appreciate that thing, and how that fear psychosis has instilled confidence in us. That talks about what kind of efforts which we have made. I will just write to take clue from the previous questions which we were asking, from where we can get the NCTC this NCD data. Because when the COVID started, we were grappling with the issue of getting data. Ministry is having 15, 16 portals, but all the program data, they don't talk to each other. That's one thing. And if you ask for data, they will give administrative data. We are grappling with the issue of having a longitudinal, even the NGOs which are working in the field, they don't have a longitudinal data. Everybody is participating in village health and nutrition days, they have having a cross-sectional data only. If I say that with your intervention, what kind of quality improvement happened to that poor woman, there is no data. Even in our respirational district, we are struggling with that. We have to see that how we improve the quality. Then we talk about the NCD data. The other thing is, it is not available. It would be available, so many members screen, so many members this. But once we pose a question, which we have been always asking, how many people they have continued the treatment after 3 months, 6 months, 1 year, the data we have to evolve. We see that how the system matures to that level. That's the issue which is there. And to address this thing, we try to collate all this data in the form of National Data Analytic Platform. Niti Aayog has come up with a National Data Analytical Platform in which all the Government of India data is there, and we are trying to see that all this data is available, and the next step, how we can see that this data talk to each other so that we can run the AI and the machine learning tools on that, so that it makes some sense. When the COVID started, I'm just citing the examples of data. When everybody say that the person who were having BCG vaccination, the COVID is not affected on these people. The second was that the people who have received the chloroquine in this malaria endemic region, they don't have this COVID infection. The people who were having a greater BMI of more than 25, 28, they were having this. They have cited the example of America. So data is foremost important, it is required. But it was an opportunity. You have seen how the things have progressed during the COVID time. One of the important hallmark opportunity which we have seen at NITI was the release of the telemedicine guidelines. When the lockdown was enforced, it was around 3 months, and gradually unlocking process started. At that time, as we all know, that NCDs are a major burden of disease. That's the statement which everybody will agree. So many people are in our system getting treatment. As during the lockdown, when we have mentioned that there was a fear, people were not coming forward, and even the private institutions, they have closed their shops and they have gone away. And it was very difficult to bring back the private institutions also. It was very difficult for them to bring their workers back to work in their institution when the unlock was happening. In that context, because in the urban areas, in the rural areas, the continuum of care is very important. And most of the teleconsultations and the telemedicine and whatever WhatsApp consultation, they were all taken on a serious note, and honorable courts have passed orders against the doctors practicing that. To give a legal sanctity to that, we were not having guidelines. It was an opportunity time, and incidentally at NITI, our member was the chairperson of the Board of Governors of MCI. We took this opportunity and got the telemedicine guidelines released. to enable the NCDs. And you see how wonders it has done. When during the second wave, when the virus have overspeeded us, and the system was overwhelmed for 15-20 days. It was a home care management which has come to our rescue, and we could beautifully manage the pandemic using our home care approach. Why? Because the enabling telemedicine guidelines were there. That's the best practice. The second thing which you have mentioned about the best practices about NCDs during this COVID time, that's an area where you can work. Because we have made compendiums. Yesterday also we have released Ayush compendiums. But nothing per se that how the NCDs were treated during this COVID pandemic and what best practices were there, then you can always think of having a compendium of that kind of practices. That's an area where the ministry, neither NITI, neither other organization I have not seen that work coming up. But it has to be specific. Not if it is COVID work, then a lot of compendiums are there. If it is NCD during COVID times, that's an area where you can always. If a theme-based has to be there, then you can always say. Then looking at the policy perspectives, I'm not yet finished. You have asked about the policy perspective. So if you are having patience, then I can continue. Otherwise, then there's no use of overboarding if you are not interested. Now, one of the policy perspective you have asked is strengthening the surveillance mechanism. One of the important lessons which we have learned that during the COVID time, you see that there are many agencies which are ministry is having one site, which every day you see MOHW COVID site is there. The moment you land on the ministry website, the COVID page is there. The data is coming from 3 sources. One from the ICMR site, one from the NCDC site, one from the other districts and your DGHS sites. And the management, disaster people also, they feed in this data. But what was the need for this when we are having an NCDC system? We need to strengthen the system, and we are pushing that the NCDC, this NCDC mechanism which is there, the National Center for Control of Communicable Diseases. So IDSP program was there, which was spearheaded by this NCDC. But why it has not come forward? Why there was a need for creating a laboratory surveillance network when the laboratory network was already there? So there are a lot of coordination issues which are now being addressed. I think you have also brought out that should be the number 1 in your learnings, not the number 3, number 4. Coordination, because you have exhibited lot of coordination right from the apex level to the district level to the block level. Without coordination, this kind of response which we have shown would not be possible. The system was there, resilience means system was there, system buffer capacity was there, and the buffer capacity was utilized during the pandemic, and you have seen the beauty of the system, how everybody has responded. It is because of coordinated efforts. That's one of the important policy directions which we have been pushing is the coordination at the different level. Even at the One Health program also, when it is coming, so many ministries are there. The coordination issues are there. Our role is to facilitate. Once it comes to interministerial thing, our role comes in. If you see how the vaccine was developed, that is also because of coordination between ICMR, DBT, the pharma, the ministry, and the other players. It's not that simple. It took 1.5 years before the announcement was happened. Before that, 6 months before that, efforts were already started. Right from having the the data for manufacturing capacity, ramping up the manufacturing capacity. You have seen the COVID Suraksha mission which was there, which was only to promote the development of vaccine in this country. So one of the important bottom lines is how to have a coordinated response. It includes, you see, initially the private sector was not there. We brought in the private sector. You have facilitated so that some coordination happens. In the vaccine also, vaccine was there, capacity was there, but how to reach the beneficiary who is at the far end with the community. Connecting with the beneficiary, that requires and brought in many other people to come into fore. So that kind of mechanism is getting involved. Apart from strengthening the infrastructure, there's a lot of focus on strengthening infrastructure. But apart from strengthening of the infrastructure, you should focus on HR development. That is all the area where a lot of focus is happening. But definitely these are 2, 3, because it's nothing new. This all pushes which are given, no new policies, but the old policies which are being pushed so that things get strengthened and you see a better resilient and better response in the system.
Sir, we can see that coordinated apex level coordination by Niti Aayog, done for this COVID. This is the best example, and a lot of those learnings we can take forward. And thank you, sir. Dr. Bhavna, your experience of last 2 years, and where you see that some of those lessons going forward, so there is no future emergency if happens, our readiness to, yes, one is we are responding to an emergency, but how to continue uninterrupted NCD service delivery. Thank you.
Thank you so much. I would like to really say here that Government of India actually did the right policy directives. As Dr. Mandal said, they had actually, during the COVID pandemic, they had issued a letter saying that you could give 3 months of NCD supply, which is actually the best practice which you could follow during any pandemic. What does the patient require? For continuum of care, that is the most essential thing. So this is one of the first lesson is that, and the doorstep delivery. How did you manage the doorstep delivery? You managed it by decentralization, which Dr. Madan has also mentioned. And how did you achieve that decentralization is because, as you have said, that HWC is managing 5,000 to 8,000 patients. They can have a line list of patients who are actually affected by NCDs. And if you have that line list, and the continuum of care is most essential for hypertension and diabetes. Other care is sequential and other requirements are there. For these two diseases, under the initiative called India Hypertension Control Initiative, we did a sort of a study and we collected the data, and we actually came up with the data that almost 40% of the patients at the grassroots level were receiving the medication. And this was done because we had a line list of patients, and the drug delivery could be managed at the doorstep. So, and the other thing which was actually mentioned was longitudinal care. In one of the key learnings from our hypertension program is we have started, I would just like to introduce my organization, Resolve to Save Lives, is working on reducing the cardiovascular mortality. And to reduce the cardiovascular mortality, you need a continuum of care. It cannot be just screening, because screening just lets you know that you have a disease. But the disease has to be treated, and once it is treated, it needs to be controlled. And that's what we are doing in this initiative. This initiative is actually led by ICMR, WHO, and the NPCDCS program. We are the technical partners in that. And we are supporting the program to learn how you can control the disease. And we have been doing it for the last 5 years. And the data is there to showcase that the continuum care can be maintained, and longitudinal data through digital platform can be obtained also, and through paperwork also. Paper forms also, because previously there was only paperwork which was being used. So all these things has been happening during COVID also. The other factor which contributed to continuum of care in NCD was the digital policy coming in. When the digital policy came in, you could use eSanjeevani, and we have a platform which is called Simple, which is being specifically used for hypertension and diabetes patients, could actually do consultation through that, because we had a policy framework, we had the regulation, and we knew how to implement it. So the whole framework was there to be delivered. Now we need to see how this was during COVID. Now we need to see that how we will strengthen all these programs and all these things we have learned over the next few years and the decade. So the primary thing which we learned was that we need a very robust primary health care system, which the Government of India is taking the initiative, and through HWCs it can be done. We need to learn from all these things. That means the continuum of care could be maintained through longer period. Because if you go to the village and rural sector, they will say that we will waste 1 day to collect our drugs. So if you give it for a longer period of time, their days of work are not lost. So these are the things which we can learn and we can take forward. And as rightly mentioned when you said that we don't have the data to support that if we do this kind of an intervention, what is the impact on our population. And that's exactly why we had this program where we took a longitudinal factor and showed that actually till now how many patients can be controlled, and the control can be really improved. So this is what we can learn and take forward.
No, thank you for your, I think those data could be good use.
They are all published data, and
mhm.
I can share the papers
Okay,
with you.
thank you. So what is your UN kind of experience, and what are those some learnings that you see, and how we can take some of those learnings into upcoming program currently, because there are some backlog also. We are kind of trying to fill that through special drives and others. And also going forward, what could be a way that we can take a couple of these learnings, like best practices, some of the examples from ministry side and some of the other partners, there are many partners outside this hall also, where you see some of those lessons, from your UN systems experience, and collectively we can see those taking forward. Thank you.
Thank you, Dr. Pola. I think my seniors before me have, very well established what have been the challenges and what have been the best practices. So one question which actually which I have is, when we say that we want to take some or learn something new or innovative from this pandemic for future pandemics. So I think this question needs to be reframed, because such pandemics happen once in a century, right? What the question should be that, what should be the learnings from such a pandemic that can strengthen the system once the pandemic is over, so that in future when any such emergency arises, we are not in the same situation. So first of all, we need to reframe the question. Why I am saying this? Because certain best practices or certain innovations are applicable only in emergency situations. For example, Har Ghar Dastak in COVID vaccination. You cannot provide routine immunization through Har Ghar Dastak, right? You cannot ask an A&M to carry a vaccine carrier on any vaccination, every vaccination day and go for. That's a special drive for a special situation, which is not scalable and which is not sustainable also. Having said that, as Sir said, telemedicine is an innovation and is a intervention which is, if worked upon, is sustainable and of course is expandable. Similarly, as ma'am said, the digital data systems, which actually in COVID situation we have established through COVID, that yes, a digital system, if it is robust, if it is easy to use, if it is and captures longitudinal data, right, it can be informative both to program as well as to policy makers. So that's an innovation which we would like to replicate in other health programs as well. Thirdly, as Mandal sir and sir have already mentioned about telemedicine and other. Another thing which we need to learn from the pandemic is the focus on mental health and increasing the confidence of the beneficiaries on the health system or the health. So for the first time it happened in the country that guidelines for prevention of harassment of children and elderly when they come for treatment for COVID pandemic in facilities was released by the Ministry of Health and Family Welfare. So that aspect was the first time which was seen through, right? The mental health aspect, as I mentioned, was seen through. For the first time, I think a treatment protocol and SOP was issued under the leadership of Niti Aayog, which was followed across the government and private sector. And also people could refer to them and, at home also, especially for the mild cases, they knew what needs to be done, right? Whether they had a health facility or a healthcare provider within their vicinity or not. So those kind of SOPs for diseases, I think that's a great learning which we can take. And similar exercises have been done by ICMR. ICMR, I think their volume 2 for disease management SOPs is already out this year, and they're looking for dissemination, right? They're looking for partners for dissemination. So we can support them. Third, I think, fourthly, I think, see, our health system is a inverted pyramid, right? At the top, we have different divisions for each diseases. Even the organizations are disease specific. But at the bottom, it's the one-man army with the A&M who has to implement everything, right? So if such an epidemic or such a pandemic or such an emergency happens, it's natural that the systems will be disrupted to some extent, or the services for other health services, other diseases will be disrupted. But what needs to be done is, to ensure, so like again, which has been iterated, to ensure measures or the system should be robust enough so that the corrective measures or the are taken, for example, the 3 months or the home delivery of medicines. So if the supply chain is strong enough, if the supply chain is not strong enough, then giving medicines for 3 months will not be possible because that medicine is not available at the health facility. Lastly, I will think the demand generation or the demand of the confidence of the beneficiaries on the health system has to be developed and has to be worked on, which is a great learning. I think COVID pandemic and the government has really worked on increasing the confidence and the demand of the beneficiaries on on the health systems, that most of the vaccinations took place in the government sector, right? Most of the admissions took place on the government sector. That was the confidence, right? Because they knew that oxygen is available there, they knew that the drugs are available there. So that confidence needs to be reiterated and developed. Also, just one suggestion, sorry sir. I think a great presentation by Sona. Just a suggestion is that, if such presentation can happen at the end of the session, such that so that the the points from all the experts are captured and then presented.
Okay,
then
that's a
would be
good
really helpful.
suggestion.
Yeah.
Before you drop the mic, one last message, that you want to take home message kind of things. Each one.
I think sir should give the take-home message, both from Niti Ayog and Ministry. Yeah, we are working from them for them. So I think one take-home message from sir and from Ministry and from Niti Ayog sir.
So instead of giving one, can I give two? Because sometimes we have to break the rule also. So one take-home message for the audience and for us also. So I am giving two take-home message. I have written it. So number one is that alone we can do so little, together we can do so much. Helen Keller. Famous saying of Helen Keller. So I take this opportunity to conclude that it is the best time for all of us to work together comprehensively, collectively, towards the common goal, that prevention and control of non-communicable disease, which attribute 63% of the mortality in the country. And that will lead us to that ultimate goal of SDG 3.4, which is reducing the premature death by 1/3. So that is the first message. We have to work together, all the government organizations, including our Ministry of Health and Family Welfare, the State Health Ministry, the district health managers, everything, and along with all the development partners, the PRIs, the line ministries, the medical colleges, engagement of the medical colleges, engagement of the corporates, engagement of the NGOs and international and national NGOs, and that is important. If you consider two important things of any program, that is, that political commitment from the highest level, from the Prime Minister level, Honorable Prime Minister level, or from the Health Minister level, that is the first agenda for any program, and the last one, I think, community participations. So that is one take-home message. And second one, I am taking just 1 minute for the second one. Second one is attitude is a little thing that makes a big difference, by Winston Churchill, famous saying of Winston Churchill. So we have to change our attitude and behavior. First, the people who are sitting in the audience and on the dais, we have to change our attitude and behavior so that, if you consider the 5 major risk factors for NCD, that tobacco use, the intake of alcohol, and then physical inactivity, and then inadequate intake of fruits and vegetables, along with environmental pollution, the air pollution, the soil pollution, and the water pollution. So for the first 4, I think we can take measures from our sides. First, from the audience and the members who are sitting on the dais. Then we can disseminate that. We can start awareness program throughout the country through primordial and primary prevention. So for that, I think we have to change our attitude and behavior so that we can adapt the change for behavioral changes, or that is called BCC. I mean, behavioral change communication. We have to starting from the home, from here, from this room. Thank you very much.
Lakshmikanji, after listening everybody, there are two messages. One is that we have to find a space in the efforts made by the government. You have to identify a space and start working, rather than waiting for somebody to say that you do this, you do this, you do this. You have to find a way. Government is now presently struggling to have the precaution dose. You find a way, because if you look at the primary series, we have completed the primary series. I think 7-8 months back, 90% of the people had the second dose. After that, the precaution this. And the Omicron infection has infected many of us during the month of January. So the natural immunity is less, and the immunity following the vaccination is also less. Now this is a space where now we have to see that how we can support the government. Similarly, you can identify space, how the screening of the total population for this, and linking them with ABA IDs, because most of the people would be having ABA IDs, so that the longitudinal data set can evolve after that. To see that that's a space, how you can venture into that and find ways of helping the government. That's a space. Second thing is, we have been talking about IEC. From IEC, we have shifted to BCC. In the BCC also, we are not making much dent. Now you have to nudge people. That's an area where you can always find space. Because these are what I understand, that you wanted a message, that what are the learnings, so that you can take the take-home message for your organization. So these are the two spaces I clearly see that where you can nudge the people, the government, and the other functionaries to implement and take the things forward. I stop here. Thank you.
Ma'am, anything?
Just my request, since I'm from a different perspective. So I'll just say that from a perspective of a population, I would say that basically primary health strengthening the systems would be really helpful in actually taking forward our NCT care. Because we are a nation where we have been usually dealing with communicable diseases. That was find, treat, and that's it. But for chronic care, we need longitudinal care, lifelong care. So we need to change our mindset. And even the government will have to think on those lines, because as rightly said by Akash, that we need systems to actually procure that much of drug to be able to deliver to every patient. So I think this is the mindset which we will have to change to actually deliver NCT care.
So just will take a minute. I think we are very harsh on the NCD program in terms of measurements of our achievements. See, for example, so I also work very closely with the vaccination program. So in vaccination, it's very simple, the coverage, right, which is not the impact, actually. It's an output indicator. But for NCDs, we want the impact, which will take 25 or 30 years to come. So I think, see, because in vaccination, we don't ask how much percentage of IMR was, reduction in IMR contributed by DPT vaccine. We never ask that question, right? So we need to, at the global level, I think, if some of us have that reach at, WHO or UN or, the people who make those indicators for SDGs, I think we are too harsh. We should focus, as Sir said, on the longitudinal data, how many people are maintaining treatment. Then how many will actually have what will be the impact on burden disease? Is it 25 years after, that? So I think we are very harsh on ourselves, sir. We should also program at the government level also, sir, we should focus on more of output indicators so that at least the systems and the processes are strengthened, sir.
Actually, they have considered all the countries, not only India, and we have a country with population size of 1.4 billion. You have to consider that. And also the population density is one of the highest in the world, 464 per square kilometer. So when you are dealing with that huge size of population in the country, with such a, infrastructure, equipments, and human resources, I think they probably think about the whole world, not only India. Yes, it's very, difficult to achieve that goal by 2030, but we have to give our best try for that. If we can give our best try, at least we can reach nearer to that level of SDG 3.4, that reducing the one-third premature mortality by 2030. That is also possible. There are so many examples. If we have an example of smallpox, guinea worm, poliomyelitis, and now the diseases which are coming from elimination, the kalajor and malaria also by 2030. So why not NCD also? And I admit one thing, that we are screening the population, 30 plus population, and once a 31 years or 32 years person is diagnosed with hypertension, you have to ensure continuum of care till death. That person may die at, if you can ensure proper treatment to that person, he will have the normal lifespan. And that treatment has to be continued for 30 years, 40 years, 50 years in some cases also. If that person die at the age of 90, maybe 106 also, who knows? The way our lifespan is getting increased day by day, now it is 70. After a few years, we can see that lifespan has been increased to 80, like Japan and other Western countries. So you have to continue that treatment for diabetes, diabetes, for hypertension, for cancers. That's a huge task ahead of us. Continuing a treatment, not like a TB, only 6 months treatment or 2 years treatment or 11 months treatment, and for leprosy also 1 year or 2 years treatment. We have to treat that person once diagnosed for a period of for 50 years. I should not say 100 years, because I don't foresee that type of lifespan. So I think that poses a huge problem for our program, and that is also that poses a huge problem for the national program manager like me.
Yeah, I'd just like to add just 1 minute to Akash's point. We are actually, whenever you want to reduce NCDs, and if you see the worldwide phenomena, trans fat was one of the factors which was creating, and India has taken the first step. So the mortality would reduce. And secondly is the salt reduction. So that will also have a major impact on disease burden. So we could achieve that SDG 3.4. So we look at in that format, it would be achievable. So we are trying to achieve the NCD control through various methods. So I think that's the way forward.
I think three experts.
Thank you, sir.
Just a moment.
Okay.
No, just a moment. I have only one second. Just a request from all these three NCD experts. We are bringing out a state health index in which everybody contests saying that it doesn't have NCD indicators. I will request all the three of you to provide me some NCD indicators which can be considered. The criteria is that the data should be available in a public domain. It can be validated by an independent agency, and there are no much fluctuations in the last 5 years data. So that the data which is measured gets monitored, gone, and results are there. So that's a beginning step towards achieving the.
So thank you very much. All the good insight. We will collect all this information and share with a larger audience also, how we can take forward.
So thank you so much, all the panelists. Just a second. We would like to felicitate. So I'll request Bhaswati to felicitate Dr. Sudarshan Mandal, sir. Bhaswati, I would like you to facilitate Dr. Madan Gopal, sir. I request Monica to facilitate Dr. Bhavna Sharma, ma'am. I would request Monica to felicitate Dr. Aman Malik.
Aman Malik is my younger brother, actually.
Oh, sorry. Akash Malik, sir, I'm sorry. Akash Malik, sorry. Thank you so much for your enthusiastic participation, physical presence, and guiding us. We'll request one group photograph. Sir. I think the discussion was so intense. We kind of overstepped our time limit, and I'm really sorry for doing that. Would request my colleague, Dr. Chandranath Mishra. Sir, please come on this dais, and we can start with the second track. And we are just, for the sake of time, we will be discussing both the sections, WASH as well as MNCHN here. So without taking much time, thank you so much, Dr. Chandra.
So thank you, Dr. Sona. As Dr. Sona said that we are merging the WAS and MNCHN due to crunch of the time. So quickly, just not from any surveys or any very scientific research, but what is our real field experiences that I am going to share on MNCHN and WAS. So that will give us a thinking space before this panel discussion. So if I will just, while presenting this, there will be some urban flavors, because what we have experienced that urban, particularly the slums areas, the underprivileged populations, the mother and children, so they are basically, they are the criticalities of the MNCHN operational issues are more critical there. So if when we say the urban things, so the population having the hazards, so there is a huge dense population, overcrowding, and the environmental pollution are there, as we all know. And the services of the children got disrupted during the COVID-19 and this pandemic situation. And when we see the more impact of COVID-19 in the urban MNCHN, particularly in the underprivileged, the slums areas. And when we talk about the children, so if we think the children, while it is starting from infant to the another age categories up to 5 years, if we say, so the Anganwadi center, the preschoolings, the spot feeding, everything is stopped. So children was more vulnerable, and the services which is most important and most significant at different ages, so that were some of missing. So the learning, so from our MNCHN programs, what we have learned that from door-to-door surveys and from our day-to-day field visits and day-to-day field implementations, that higher level of anxiety and depression among pregnant women and mothers. So when we talk in any pregnant woman, so there is always, the panic still is going on in the post-COVID phase. So there are some shadows, the shadow memories is working there, that there was something that everything was closed down, and there is some, very disturbing situation. So that was not only concerned to their health, but their economy, their livelihood, their, routine normal life somehow disturbed. So as a, result of the disruption in the routine services, huge dropout in the ANCs and the immunizations that we found. The wing, growth monitoring and new registration, so there is a huge gap. And positive, so every negative things gives us a positive findings, so that we have also found. That communities somehow now are caring and listening the health messages, which was earlier we have experienced was not so caring. Because now community somehow felt that yes, health is an issue and health problem can disrupt our life all of a very sudden, very quickly. And it could be disturb our life from every corners, from every angles. So whether it is economy, whether it is education, whether it is your social life, so yes, health problem is a serious problem. So health need to be care. So this is one thing that from earlier, that is not that every people, every community are now very sensitized and caring and rushing for the health services, accessing the services, but at least the attitude is somehow, the last panel discussion we are talking about the attitude. So somehow there is a little bit shift in the attitude. So increased awareness on was, but practice is still a challenge. So was, because time we saw, our top leaders, our Honorable Prime Minister, our all Honorable Chief Ministers are talking about was and social distancing, was and social distancing. So every media is penetrating on. So somehow that penetrated and contemplated situation to the community. So that was came from bottom to up. But still the situation is now controlled, so the practice is a challenge. So without taking much more time, I'm just quickly flashing on some strategies that we have targeted intervention. So in post-COVID situation, we screening each and every one, all children, all pregnant mothers, all pregnant women and all mothers. So thoroughly, so for children, we are taking the case histories and some anthropometric measurements, and as per the cases, as per the case histories, we are immediately, so there we have in collaboration with the government system, so we have developed some referral slips. So projects, our volunteers and the ASAs and the who are the service provider there, so they are immediately using the referral slips, so that are being immediately attending by the system and connecting all mothers with the services immediately. So we are trying to integrate WAS in our MNCHN program. So integrate WAS means WAS earlier was there, but integration of WAS within the routine program service deliveries. So we are trying to increase the home visit and community meetings, which was completely missing during the COVID, and group counseling in addition to targeted reach. So outreach health camps with the urban municipalities, with the other health systems, with whosoever are involved in the system. So we are trying to increase as much as possible the outreach services. So the strengthening the capacities of the service provider that we are doing, and we are concentrating both the sides. When we are talking about the capacity building, so in-person training, in-person capacity building, so there are always, there is a need, the refresher courses. And because the digitalization, the virtual platforms, there are limitations, but still we are continuing that model because of, thinking about the future, as well as we are, trying to organize the in-person training, because, there is a huge gap, the routine capacity building program which normally, goes on. So that was somehow missing during the COVID. So way forward, so continue bridging up the gaps along with uninterrupted services and care to new cases. So whatever the gaps that we left behind during the COVID, so that is to, that block lab has to, heal up and should come on the same page, as well as to registration of the new cases and serving continuously. A holistic approach of key departments and community jointly, combination of digital and direct services. So we are emphasizing the both. So digital, this is actually somehow a gift for the country, for us, that we were not so accustomed with the digital things, but COVID has given us such a space that we compelled to learn those digital pieces. So we are continuing, we are not want to lose that space, as well as we are not only to depend on digital, so we are connecting the both. So of course at the same time we are trying to be ready with plan B if there is tomorrow is any health emergencies come again or such situation, so that the normal services is not interrupted, it should be uninterrupted. So that's about the MNCHN, and due to time crunch, I'm just taking permission my colleague Mr. Alokji to continue the WAS presentation, and then we will just start the panel discussion here. So WAS programs, that was a vast programs of PPHF. So we intervened in several states during the COVID-19 phase also. So the 21 days practice strategy even works during the COVID-19. So that was a model of 21 days. If with the demonstration at the community, at the schools, at the children, so if we practice 21 days continuously with the techniques, you will be continuing that practices till the time in long ways, okay, and that will you cannot forget. In fact, it will be come in your routine life. So that is such a cost effective model that has been proved. So that has been implemented with the Unilever support by Save the Children and PPHF jointly. So demonstration of hand wash practices in effective to transfer correct techniques, so that was proved. And platform like AWCs and other health outreach sites and schools, so that was the demonstration sites for this health in this was intervention. So convergent actions, so that was one of the priority area for WAS, that is health, ICDS, HRD to integrate the school system. So PRI etc. were the key promote to WAS for this program, and address supply gap ones. So we also tried to address whatever the supply gaps were there, to address that. So the approach for WAS was to catch in early stages. So when there is a pregnancy, the time the child is not born, catch at that present. Then pregnancy, newborn, infant and children, so that WAS continues. Then what is the chances, that is a higher probability of continuity. And add school children integration in the school curriculum. So it is important whenever we are talking about WAS. So one is the basic things, the soap and the water, when we are talking about the hand wash with soap. But the integration in the school curriculum, so nobody talks about actually WAS, okay. So we only, when the people like us or the Women and Child Development Department or the Health Department go to the schools and then start talking about. So why don't it comes in the routine curriculum? Why don't we talk about the WAS in our routine curriculum? So then it will be in, only then it will come into our life. So that is the approach, and then influence the community also. So because ultimately that whether it is school children, whether it is pregnant mother, whether a doctor or whether it is a ASA, all are coming from such any type of community. So that community should be influenced from any type of cross-sectional activities. So way forward, integrate WAS in public health and school health programs, intensify intersectoral collaboration to include WAS agenda for improved health programs, streamline WAS with available government schemes, because there are so many schemes, but it is not streamlined. So uninterrupted monitoring and promotion of hand wash with soap and other components. So when we talk about immunization, so there is a monitoring system, the monitoring tools in place. But when we talk about WAS, something is to come into the place for continuous monitoring. So continue the momentum of WAS acceptance and practice during COVID-19. Again, that momentum created during COVID-19, because that was the time That was the need of the emergency time. But now if the emergency time is gone. So the question is whether we are able to continue that momentum. So we have to effort for that. And address the supply gaps, because we are always concerned about our drugs and other things. But what about the basic things, the water supply, the soap, the minimum things actually required for continuing the wash, and the facilities should be available. And emphasize regular reporting, supporting supervision and ownership in the community. So these are some of the snapshots of our WAS efforts during the COVID event. And that's thanks about the WAS and MNCHN. So before I just go to panel discussion, just in 30 seconds, I will call our project manager in Kolkata Urban Project, Dr. Antara, to come and in 30 seconds just share one very key experience that you have experienced. Because we are going to time crunch, so I'll just say 30 seconds to 40 seconds. Just share one experience, please.
Most of the part Sir has covered. I am just telling about my experience. That is, in the urban slum is a challenging that we all know. And when we are intervening the urban nutrition project, health and nutrition project, we are finding that during the COVID, the screening process through ICDS was totally neglected. And it was difficult for the ICDS to screen regularly the children and to identify them, and to refer for the proper services was little bit challenging. That's why we have started the screening camp, and we have identified the severe underweight children and the severe acute malnourished children, and referring those children to the ICDS and the health department for the better services, so that they get the proper health services and proper nutrition care. And it was just mentioned that the mothers are now getting, try to understand that what is the health-seeking behavior, because now they can understand that the health is a really wealth, that COVID situation they have learned these things. So it is a little bit energetic for us that the mothers are getting, coming with us, so to understand that what is the health-seeking behavior, and they are interested to to take the advantages from the services. So it helps us lot to go ahead the projects. Thank you.
Thank you, Dr. Antara. So it is now my pleasure now my great pleasure to invite our MNCHN and WATS esteemed panel speakers. So I would like to first invite in the dais Dr. Suranjan. Had long and distinguished career of 32 years in the Indian Administrative Service, and held key position of responsibility and leadership in various departments and ministries in both the state and government of India. He was also Joint Secretary for 5 years in the Ministry of Women and Child Development. He also served about 2 years as Joint Secretary and Additional Secretary to Government of India as Deputy Director General in Unique Identification Authority of India. Sir, it is my pleasure to invite you as a esteemed panel speaker for MNCHN and WAS in the dais. Secondly, it is my pleasure to invite Dr. Kapil Yadav, who is MBBS, MD in Community Medicine, is currently Additional Professor at the Center for Community Medicine, All India Institute of Medical Science, AIIMS, New Delhi. Dr. Yadav has published over 115 scientific publications in national and international journals. He is a member of several committees constituted by Government of India in domain of nutrition, anemia, iodine deficiency disorders, and public health. So, sir, Dr. Kapil Yadav, please be with us, and thank you, sir, to join with us today. It would be my pleasure to invite Dr. Anchita Patil. Dr. Anchita, having 18 years of public health experience, she is a MD in community medicine. At present, Dr. Anchita Patil is the lead of MNCHN in BMGF. She started her career with Government of India and worked with USAID and UNFPA. As a independent consultant, she has worked with UN agencies and World Bank. Ma'am, it would be our pleasure to invite you in the dais as a panel speaker, and thank you for joining us. I would also thank you, ma'am, joining in this panel. Now, it would be my pleasure to invite Dr. O.P. Singh, who is a PhD and postgraduate in health management. And at present, he is heading program management, health and nutrition in Save the Children. He has 20 years of experience, and he is an expert in WAS, particularly in different works with nutrition, maternal and child health, and WAS in a holistic manner. So, Dr. O.P. Singh, I would request you to please come in the dais and join with us as a panel speaker. And now, it would be my highest pleasure to invite Dr. Sujit Ranjan with us as a facilitator for this panel discussion of MNCHN 1 WAS. I especially thanks to Dr. Sujit Ranjan because I know he just landed today from Mumbai to Delhi in last I think 1.5 hour ago, and just is rushing to this hall and agreed and joining with us as a moderator or facilitator for this panel discussion. Dr. Sujit Ranjan is 30 years of experience in public health. He has given his meaningful leadership to Care India as a state head for Jharkhand for long time. At present, he is working with Tata Trust as a associate director. He has also worked with Magic Bus. He has also worked for Nutrition Coalition. He has also worked for PFI and lot of organizations. So Dr. Sujit Ranjan having a very vast contribution in this sector. So sir, it would be our highest pleasure to invite you in this panel discussion as a facilitator, and thank you for joining with us. Sir.
Thank you very much, Mr. And good evening, everyone. I can see like it's almost 4 o'clock and we have to close by, I think, okay, good. But half an hour is enough good time. So the crisis brought us together again with more focused deliverables and the objectives. And today, we are honored to have the presence of esteemed group of panel members consisting of policy leaders, program leaders, and we are looking forward to hearing their valuable views, valuable ideas, and that will be very, very important for each one of us, like the public health professionals, how we are taking this journey forward. So without taking much time, I would like to, couple of things were coming in our minds, sir, when I was listening the previous panel discussion, like it's very important to understand like how COVID, considering COVID as a kind of catalyst for changing healthcare delivery in post-COVID phase. Like, so we have learned the COVID and what lays forward for bringing the program implementation gaps in both urban and rural areas. We have identified. Now it's very important like what is our learning and how that learning is important, like going forward, how we will be prepared ourselves in such a manner so that we can deliver the quality program in such kind of crisis. Because this was one of the, I think in our whole life, first time we got an opportunity to see such kind of crisis and such kind of challenges. So I would like to first go back to you, sir. Like you are having such a vast experience in government, and it's important to learn from you, like how we can bridge the program implementation gaps in urban and rural areas in future after the COVID. Now we are say the new normal. How the learning is useful and learning is important for us.
Okay, thank you, Sujit. I think it's a pleasure to be back amongst the nutrition and health people. I have experience of 5 years as health secretary in government of Meghalaya before 5 years of ICTS experience. So I thought I'll put that in perspective. I'm a non-health but biotechnology man, and have an upbringing of natural science. So I have a totality of view. First is that health sector must break its own frontiers of its apathy to different pathy to no pathy. That means basically sympathy. So there should be this classification or castification of allopathy, homeopathy, and naturopathy, and all those Ayurveda and other thing. So cultural context and the wisdom, traditional wisdom, must be filtered, and this frontier has to come. The problem is that commercialization is invading our social norm, ethics, behavior, and perhaps some of the advice from some corners are coming from that side. Now, second point, I will be raising more questions also. I don't have answers. When I was health secretary in early 2000, I was told sub-center in this country is 1,40,000. Today we heard that sub-center is 1,30,000, and they are aiming to 1,50,000. So 20 years, sub-centers more or less in numbers remain same, right? Same is the situation in public PHC, which is now called Health and Well-being Center or whatever, Wellness Center, some of them, the better ones, and the CHCs. Okay, numbers haven't changed. The aims have come, tertiary systems have come. So the question is the system victim of more fragmentation rather than convergence, rather than integration? The second point which emerges everywhere in all program, and I raised it say outside during lunch discussion, why is coordination and convergence not ensured or not happening when the job of leadership, both the CM, CS and DM, okay, is to enforce that, right? So, is it that they are giving up? Or is it that they are feeling helpless, or their tenure is small? Is the politics of 5-year, 10-year is driving the, is reducing the governance of systems to 5-year short-sightedness rather than a long-term sustainable system driving? Right. So I'm raising this question, which is which to my mind drives the priority. If the priority is to evolve a system improvement and sustainable system, then perhaps we do that. Now so the question is, why, I'm unable to understand, Sujit, you have worked in Nutrition Coalition and others also. Why is IYCF not improving? Why is routine immunization not improving? Okay. I just heard the previous panel telling it is impossible for A&M to go and deliver immunization at home. I don't think it is impossible. Right? There isn't will, there isn't that dedication or commitment. So the question is, at the community level, is there trustworthiness? Have we set better examples? Okay. Have we dedicated our systems, our behavior, our conduct as a public servant or public service delivery, okay, has it gained the trustworthiness of the people or the masses? Why is that people prefer immunization going outside, okay, disrupting those who can afford? Why is it that we are now bringing this? So these are issues which I thought I'll bring in. So behavior change both in WASH and also in health adopting system is linked to your education conduct right from your childhood. Whatever you are told at home, whatever as a good conduct, good behavior, neither the education at home nor the education in school has health behavior or the conduct as the norm. Okay. Now the maternal child protection card was supposed to educate, joint MCP was supposed to educate mother and child, particularly the mother and the parents, right? It was also supposed to be educational tool. It was also supposed to be a monitoring tool, okay, both at the community and family level, whether benchmarks or the warning signals are happening. Now, during COVID, we saw that child care services have totally been disrupted, okay? Now, wherever the parents were conscious, educated, etc., they took good care of the children at home, right? But why even at the community or hamlet level or habitation level, the growth monitoring could not be educated to the mothers, right? There could have been circulation of equipments with proper sanitation, okay, and measurement taken. Home visits to house was supposed to be done. Now, somewhere the community workers are working, I would say, in non-core job more. Anganwadi workers are known to do non-core job more than the core job, right? And somewhere for every job, because of ASHA and incentive and other things happening, for every job, they are looking for this. Right now, for incentive or for some gratification, either informal or formal from the system or informal from the society, right? Now one more point about nutrition. I was aghast that you can give grain during, say, Garib Kalyan Yojana and you can continue, which is a great effort to mitigate. But the fortified THR, which you could have delivered in a better way at home, why that got disrupted? Because there was a policy shift, or perhaps I do not know where from that is happening, because you think that nutrition of child is supplementary or marginal. Or somewhere you come from, no, it must come from SHGs, livelihood. Is the child secondary to the adult's aspiration? I'm raising a question. So this is where I think we need to, you heard that home care management was adopted. Home-based care was also given in respect of Sneha Shivir and other thing, in respect of the children. So I personally feel that that needs to be worked on. Okay. The second aspect which I thought is, this is true, as the report has mentioned, that urban area was more affected because rural area had sense of community, sharing, caring, and other aspects. But in urban area, isolation becomes more issue. And the WASH program, apart from behavior, you are aware that National Food Security Act has a mandate that every Anganwadi or every school will have water and sanitation facility, right? It is a mandate, right? Yes. Has anybody evaluated how many of them have? I have visited, right now I'm doing a survey and under my fellowship, and I find that in Jharkhand, the Anganwadis are, even post-COVID, are not getting THR. The salaries of Anganwadi workers have not been paid for last 18 months or 8 to 18 months. I do not know why. And this is a situation of cash surplus, okay, a state or such as Jharkhand, okay. So somewhere I think we are burdening, somebody said inverted pyramid. Somewhere we are burdening the worker, abandoning and leaving this, and perhaps data management, data showcasing is more concern than the actual delivery. Okay, so I will stop here. Right, thank you.
I think, sir, you have raised lots of valuable points, and I totally agree with you. Like this was a unique opportunity to build or to strengthen our public health system, care system, nutrition system. So that's why your learning is very valuable for each one of us, and maybe we'll go for get answer of lots of other questions which you have raised. Now, sir, we are having Dr. Kapil Yadav, and is a well-known public health professional and a very dynamic public health professional. And I'm having a question again based on the discussion today. Like, what is the most pressing issue, like facing healthcare response and management today? So I'm talking about like after the COVID and the phase new normal, and how can we, as public health stakeholders, leverage the experience of COVID to rethink what we are doing and what in the healthcare system. I think since Dr. Kapil is involved in so many public health forums, I think he is having all ground realities and policy related issues. So Dr. Kapil, your response will be very valuable.
Thank you, Dr. Sujit, and thanks, Dr. Lakshmikant, for giving me this opportunity. As an opening statement, I think what COVID did was put a world on a pause and made us rethink what we are doing. Are we doing it right or not? And I think I'm a born optimist, so I look at everything with that key, with the glass of optimisms that so there were a lot of negative fallouts, but that did make us think. Most of us were confined to our houses and we were forced to think. So it highlighted the fragility of human life. We had got to maybe assured that we own this world. So COVID, a small virus, made the world realize that we don't know much. At the same time, it underscored, after initial few days, underscored the importance of scientific temper, that it can be overcome only through science. So a lot of research went in, and from that perspective, we as a doctor realized we don't know much about the human body. So we went back to our textbook, and that's where I think the role of scientific temper came into picture. And the last was the resilience of human spirit. So even today we don't know much about COVID, and I'm very upfront and honest about it. But what gave us hope and why we were able to overcome it was the resilience of human spirit. So we said the stopping and sitting in home is not an option. We have to come out, and we don't know much, but at least we know some things. So after initial month or two, there was a lot of knowledge that was available, and we worked on that. Coming to the question that Sujit posed, what is the most pressing issue? It's a very difficult question to answer because there are so many pressing issues that are confronting healthcare. And COVID exposed us royally. It exposed our deficiencies. We were not able to meet basic requirements. In the hindsight, now we know a lot. So we are now familiar, oh, maybe even if we had this, even if we had sufficient oxygen available, so many lives could have been saved. So it exposed our deficiencies. So, and if pinned to ground to raise one issue from healthcare perspective, healthcare response and management, I think it would be the resources that are allocated to healthcare. We as a country are gloriously underfunding our healthcare. 1% of GDP is not sufficient to take care of any population anywhere in the world, whether developed, developing, underdeveloped. And that surprisingly nobody challenges. That has, despite COVID, that percentage beautifully has stagnated around 1% of the GDP. There have been so many new initiatives. Every day I hear a new program being launched. But beautifully the policy makers or the powers to be keep the funding at the same level. So with this much amount of funding, whatever innovation strategy you may resort to information technology, and sir mentioned very rightly, we have replaced it with something else. We have forgotten what we were doing right. You have given those iPads and tablets to the workers and taken away their THR. So you have replaced one thing with the other. The overall kitty has remained same. I'm honest and blunt about it. There's no beating around the bush. Both in health and science, we have managed to maintain the same level of funding, and from that flows the various struggles. We are trying to, as a implementers, I'm right now sitting in a rural hospital 35 kilometers from here. So in the same kitty we manage कि इसको ऐसे जोड़ के ऐसे तोड़ के कुछ better कर ले. पर struggle है overall तो उतना ही मिल रहा है. Even in nutrition, if you look at, overall kitty remains the same. एक चीज को हटा के दूसरा, that is I think maybe the most important challenge. And second part was how we can leverage the experience of COVID to rethink what we are doing in healthcare. I think the one message that COVID, to me personally as a personal level, was that try to reinvigorate the scientific temper. We as a society, historically Indians were known, I'm deliberately using the word Indians, culturally, we were always known to question things, right or wrong. Shastrat part tha, matlab ek na society ka, ki you will flag a question and discuss. Without taking position, it may not be right or wrong, but question everything. So that scientific temper, it's written in our preamble, Article 51A says, it shall be the duty of every citizen of India, H, to develop the scientific temper, humanism and the spirit of inquiry and reform. Unless until that is done and we learn to challenge the established dogma, because COVID showed that whatever the understanding was, we had in our medical, as a medical doctor, it was harrowing for us in the hospital during the first wave. We didn't know what hit us. There were so many patients coming and bodies coming, and so we went back to the science, let's look at the literature, what it says. And literature finally after a year or so said nothing much is to be done, supportive care. You don't require aggressive intervention. You don't require ICUs. You require a oxygen, a simple oxygen, and maybe a very minuscule proportion requires steroid, not a long duration steroid, and you'll come out of it. So if you learn to question and discuss and debate, I think we have the solution both in health and in nutrition, and they have a lot of overlapping areas. So that's it from my side. Thank you.
Thank you very much, Dr. Kapil, and it's very, Dr. Kapil is always very frank in sharing his experience, and the recommendations. And if you reform our public health system, now it creates opportunity for ripple effect areas like nutrition, water and sanitation, even education and other social sectors. So it's very, very correct. And now I would like to request Ms. Anchita Patil, she's having very vast experience in MNCHN, and based on your experience, how important is the coordination and collaboration, whatever we have learned in during the COVID, collaboration and coordination among multiple stakeholders at different levels, essential for MNCHN services and to delivery to the last miles. I think this is Bill and Melinda Gates Foundation, with the help of various their partners, contributed a lot. So your experience is very valuable, how we can learn and how we can incorporate in our plan for the coming days.
Yeah, thank you. In fact, we were talking over lunch about this coordination and collaboration and how that is probably one of the most difficult things to do, because all of us work in silos. And the silos exist, even at absolutely minuscule levels. So within the health department or health ministry, and I'm loath to say this, but say there is a silo for maternal and child health, and the newborn, we don't know where the newborn is, for example, here or there, post-delivery. Even within, if I talk about maternal health, different program officers will be looking at different elements. So somebody's looking at quality of care, but somebody's looking at abortions, and they don't seem to, see the program in its totality. And what to say about, where we need much more collaboration. Nutrition is deeply linked, but we don't have WCD talking to the Ministry of Health. And of course, the others, if we need health care, we want to have roads, we want to have communication to be able to do all that. But who's talking to whom? And that needs to be brought on at the district level, as Sir rightly said, at the state level, at the district level. Whoever the lead is, needs to bring it all together. And some of the review processes that we have, at least, because I look at MCH, do give us that opportunity to do that. So for example, and this is not COVID specific, for example, if you are reviewing a maternal death, it has to be done under the leadership of the district magistrate. And that's for a reason. Because if transport was an issue, if road access was an issue, if late communication was an issue, that's not an issue that the facility or the health department can solve. But it's an issue that, can be solved at the level of the DM, who sits there and looks after all the other elements. But on the positive side, I was, when I was working with the foundation, I was given a very interesting task of actually look at what are the possible innovations that are going on and what we could use to what they were calling Build Back Better. So I, from an MNCH lens, I started looking and I started talking to people, and I found some very interesting interventions going on. Some of them, absolutely showcasing this principle of coordination and collaboration. For example, within health, we know the frontline workers were absolutely seized with COVID-19, and they had to go for home to door-to-door visits and inquire about symptoms, etc. But in the state of Bihar, for example, what we learned is that at the same time, the same frontline worker was also doing her FP-related duties and carrying contraceptives home. Because now we had the migrant labor coming in, and the men folk coming in and staying there, and they needed contraception. So, along with the surveillance visits, how to tag it along, which should make logical sense, but generally doesn't happen. So, the infectious diseases team is working separately. But then it is the same frontline worker, that inverted pyramid that was talking about. So she was used to deliver contraceptives also. Of course, we really need to think how to take this forward, in the larger sense, that our home visits, we don't view them, in isolation. Acha, itna HBNC kiya, itna HBYC kiya, itna. We can't do that. We have to build it as a whole continuum, and that's still missing. Even from a guideline perspective, it is missing, almost. The other thing, a similar example was, between two departments. I was talking to a colleague in Assam, and she said that they were using the disaster management helpline that was fully functional in Assam to actually address each and every query. So if people were running short of food, they could call and say, we need food. If people wanted emergency transport, they could call up. If, they wanted to know where should I go for delivery, which facility is open, where can I seek certain services, they were given that. If they wanted home delivery of certain drugs. So it is like the disaster management and the health team and the food supply, everybody seemed to have come together and used that one functioning system to deliver more and more. So I thought that was an interesting model that we could, probably explore for other things rather than, again, creating vertical silos. What I also saw, was the way the professional associations had come on board, and I'm talking of the health professional associations. What I saw was the speed at which guidelines, latest technical information about management, prevention, who's saying what is government, it was being spread, at the speed of light, probably faster, exaggeration, but how everybody seemed to be talking to each other. Institutes like AIMS, was holding webinars along with Government of India, and there was like a whole coordination going on. So it was very interesting to see, and for the first time probably, what I also heard is a channel from the professional associations back to the government, what they wanted. For example, one of the things that I remember them asking for is that, we are putting our lives at risk, and we are at serious risk of getting infected. Can you assure a single facility that is just dedicated to the healthcare providers? So that was a request they could send. So that kind of two-way communication, and the speed at which it happened, I think it talks of coordination, and if we can develop that into more formal mechanisms between the professional associations and the government, and maybe take it to the next level of getting the partners on board, that's something we should look at in terms of coordination. On the other side, the other coordination was at the development partner level. For example, all the UN agencies came together to form the 8-6 and came up with collective guidelines. So which is something UN has been doing previously, but I think they came together even in a much more coordinated fashion to tell them. Of course, the guidelines kept on changing, but then that is the nature of the thing, because we still don't know much. As Dr. Kapil said, we were learning as we went along. So there was a lot of learning that went on, and not just in terms of coordination and collaboration. There were other very interesting things that happened, and I was just noting, from the list that I developed 2-3 years back. For example, telemedicine. It came up, and it was referred to in the previous section, how the telemedicine guidelines finally received the stamp because it was much need of the hour. We also came up with very innovative means of quick and dirty data collection. Phone interviews became, the absolute source of information, and partners were sharing data across with each other. So if even with that, then I remember we do work on financial security. By we, I mean the foundation. And yet, we had our teams talking about poverty, impact on nutrition, impact on health, and, what people were facing, whether they were getting food, and everything was also being disseminated to other like-minded partners almost at lightning speed. So this is something, that we probably should formalize and continue even post-COVID era, and as we call it, build back better?
Very valuable learnings you shared and evidences. I think at system level, in development sector also, technical organizations, how they came together. So now we the spread of COVID-19 definitely affected or impacted the health, nutrition, livelihoods, wash and well-being of India's most vulnerable population, and will have lasting effect on people. So now Save the Children is one of the very important public health, a very valuable contribution in public health, and Mr. Singh is here. So I would like to request you to please share some of the initiative taken by Save the Children, and some of the, if you want to share some of the highlights or the evidences, how you collected the evidences, and reframe of the strategy also to deliver the program activities differently for future. And if you have any kind of experience, any learnings, you are most welcome to share.
Thank you, sir. I think before I come to that point, let me just share a couple of thoughts. Okay. Yeah, now fine. So I think I am, as you are optimistic, Dr. Yadav, I am also very optimistic. I am thankful to COVID actually, for multiple reasons. I am thankful to COVID because it has shaken up the world to rethink about their existence, about their strategies, about their work. So basically, one of the factors that I could see very much popping up in the world is water, sanitation, hand washing with soap and water. I always used to wonder what has worked in COVID. So we work on behavioral insight and try to understand what works at that time. So generally we call a term we use nudges. So nudges are techniques that convert for practice. So we found that the fear of COVID has been the biggest factor for people for acceptance of any kind of COVID appropriate behavior. Maybe hand washing, maybe face masks. Now we see a lot of relaxation is there. So even we all people are, not doing all those kinds, because that fear has gone out of our mind. And to be frank enough, we are inviting back the fear to us. So let's see how we deal with this, because in last session I heard that somebody told these kind of epidemics happen once in 100 years. Because they happen once in 100 years because we do not learn to deal with them actually as a human being. We forget them. Now moving back, so we were in the WASH times, in the COVID times, along with PPHF in the 4 states, we had implemented a hand hygiene program across there, and had a very quite interesting learning that how a behavior change can be incorporated within the communities, within the groups, within the schools itself. And it was rightly mentioned in the presentation also that it's all about how we can sensitize them, how we can observe them practicing for at least 21 days, and then follow up and reward them for that change that they bring within themselves, for the change that they bring within their community members actually. So that kind of approach is much more required and needed at this moment of time. Another very important aspect is on the accountability aspect actually. So there has to be accountability fix within the line department when you work, and not only within the line department, but this accountability should be within the cross-functioning department also. So it's not that health is only work of MHFW. So it maybe the WCD, maybe the other department, they all should be well-defined framework with clear-cut functions and duties should be spelled out. Most of the time we ask questions why the coordination does not work. Coordination does not work because our targets are not interdependent.
Right.
So all are individuals actually. So we all run after that single thing without leaving all those kind of things. Till the time this will happen, we can live about coordination. We cannot talk much on that. One of the very changes the COVID has also shown about a vast difference between the rural and urban wash scenario actually. So we very well know that the rural wash or sanitation aspects, they are far behind the urban one. For example, if you say Ladakh, in Ladakh you will find that the rural sanitation is 40% gap than the urban sanitation. In most of the portion, the thing is that. But just the opposite is happening in Northeast India. You go to Meghalaya, you go to Sikkim, you will find a reverse trend. Their rural sanitation is more than the urban sanitation. Now, India is a country which is the third largest country which produces solid waste. Now see the danger it is giving to us right now. And out of that, only the 70% is collected, and of the 70% collected, 80% is dumped into the open land. What happens to that? It goes into the open environment, and what is doing to us? So we are facing in a huge crisis right now. So in the terms of now working on moving ahead in terms of this, we need to strategize ourselves. We need to have a sustainable investment to work towards it actually. That we want to say.
Good.
So thank you so much for your time.
Thank you very much. Thank you very much. And I think in a short span of time, whatever we have learned and whatever we are having the very inside story, like how that will help in our plan, how we can, when we will go to the drawing board again, how best we can plan in a more better manner. And COVID, like sir has rightly mentioned, COVID-19 is a unique opportunity to reform our public health sector, and a strong public health system will benefit everyone, and there is no better time to make it happen today. Thank you very much to all distinguished panel members and for your valuable suggestions, ideas, and take this agenda forward. Thank you very much. Sir, 1 minute.
We are at the age of this panel discussion, and thank you all our distinguished respected panel speakers for joining us, and Dr. Sujit Ranjan to facilitate this whole panel discussion. And now I will request Kritika to felicitate Dr. Suranjan. Please. Sir. Thank you, sir. Dr. Antara to Dr. Kapil Yadav. Thank you, sir. Kritika to Dr. Anchita Patil, please. Thank you, ma'am. Antara to Dr. Sujit Ranjan for facilitating this session. Yes. And Kritika to Dr. O.P. Singh for joining us in this panel discussion. Thank you, sir. So now I request Dr. Sona to give the vote of thanks. Thank you.
So as the event is coming to end, on behalf of So on behalf of PPHF organization, I would really like to thank all the eminent panelists who took out the time from their busy schedule, all the distinguished audience. I think without you, this program is not successful. So all the distinguished panelists, audiences, and my state team who traveled across India came to Delhi. So thank you so much, all of you. Everybody, I'm not going to take name, but thank you so much for being here, making this event extremely successful. And we are really hopeful that this is just the beginning of a health dialogue series. We would be coming up with more focused topics further on. So this is just the